September 11th, 2020, and we'll go through the COVID-19 numbers as reported through today. So globally, we're at 28,268,970 cases with 911,282 deaths. In the U.S., we have 6.4 million cases with 192,381 deaths. If we look at the global numbers, we're starting to see some changes at the country levels. So now, if we look at India, they have the second highest number of confirmed COVID cases with 4.5 million, and they're third in the number of deaths related to COVID at 76,271. Brazil has reached the second spot in terms of deaths. They're at 129,522, and they're third in cases with 4.2 million. We are also seeing a reactivation of COVID in many areas that in the last several months had put in measures that caused the trends to go down. We don't know if what we're seeing is a continuation of a smoldering first wave or if it's a legitimate second wave. And that won't be understood further until additional investigations are conducted, looking at the genetics of the virus and looking at the population in terms of what their exposure level was and what their likelihood of being infected with the same strain that was circulating prior. In the state of Alabama, we have 136,703 cases and 2,333 deaths. In Mobile County, we have reached 12,783 COVID-19 cases. Among that number, 314 of those are considered probable. This is an increase of 39 since yesterday, since Thursday, September 10th. Our number of hospitalized patients has increased by 13, and we've reached 1,889. The number of our citizens in Mobile County that have died is at 283, 6 of which are probable, and that's an increase of 4. So I don't have the percent positives for you today. We typically put that out in our expanded report, but it is look back at the last 2 weeks, and we documented 557 cases in Mobile County, and that was in 6,338 diagnostic tests, so that we're not including the antibody test, and that gives us a case or a testing infection rate of 8.8%. As we look at the breakdown of demographics, we still see more cases reported among females and fewer among males. I do want to remind you, though, that those numbers are case reports. So case reports in themselves without context should be limited in terms of how we interpret those. And if we look at the percentages, then please understand that these are column percentages and not case infectivity rates among females or males. We still see the same trend in the number of cases when we look at age group, with the 25 to 49-year-old group still contributing essentially 38% overall with the cases compared to other groups. If we look by race, we have African Americans and contributing 34%. Again, of the cases reported, this is not a infection rate among African Americans, but it's on the vertical. 1.1% among American Indian / Alaska Native, and then the white population is at 23%. Fatalities, when we look at those by race, African Americans again continue to contribute the larger number to the total number of deaths at 52.3%, and whites are contributing 40.6% to those numbers. Our total hospitalized to date numbers again, are at 1889. That's up 13. And our currently hospitalized number is up 4 from yesterday at 83. If we turn to our complaints, we received 6 complaints in total. 2 were from food establishments, and then 2 were from retail, and 2 were uncategorized by our system. So since we didn't have a lot of questions today, I did want to spend just a little bit of time on the numbers, because I get asked quite a bit about, well, what do the numbers mean and why are they moving so much? And what is the legitimacy behind these numbers? So I want to caution everyone, particularly those that try to really dig down into the numbers, is that these are estimates from cases that typically self-present for testing. So this is not a random sample of our population. And within that aspect or that sampling framework, there come biases. And when we think about when a person goes from being tested all the way through until we get the lab values, there is a lot of things that can change. Patients can be retested, etc. And I have a question that refers to that we'll get to in a minute. But these numbers can be revised either upwards or downwards depending on how additional data comes into the system. I think one of the biggest things for me as an epidemiologist and looking at the numbers is that we have fewer tests being conducted overall. And I want to, again, caution everyone on that, because the lower number of testing that's being conducted results in those metrics being less representative to the entire population. So if we think about, we've actually had a very dramatic drop in testing when we were doing strictly PCRs from the labs until the time where these rapid tests became available. And the changing in the numbers and the confirmed number that are truly positive or truly negative varies quite a bit between PCR testing in a lab versus the rapid or point of care test. And that's where we start to see these questions around, well, I tested positive, then negative, then positive again, which you shouldn't be doing anyway. If you are confirmed positive, you're going to be positive. It's when you're confirmed negative by one of these rapid tests that the guidelines say you need to have that negative result actually retested by a laboratory-based PCR. So let's talk about confirmed cases for just a minute. If you look at that number on one day, that number is absolutely meaningless in most cases. The reason why is that number can't be interpreted without context around it. And additionally, the way that the labs report their results to us sometimes are delayed or held by that lab. So we may get 0 reports from a lab on Wednesday. They report essentially 2 days on Thursday, and it looks like we have this spike. So what I would suggest is looking at the long-term averages, the 7-day and the 14, with the caveat that our testing numbers are going down. So, for instance, if people that are more at risk or feel that they are more at risk to being infected by COVID or the SARS-CoV-2 virus, I think that they're more likely to go for a rapid test to know quickly than waiting a minimum of 5 days for that. I also want to caution you that any increase in the amount of cases does not mean that we necessarily have an increase in infections, or a decrease meaning a true decrease in infections. I want to go back to this point because this is not a random sample of our population, but a self-selected sampling scheme where people think they need to be tested or it's recommended by their physician. So unless we're really doing a random sampling of a population, the true infectivity rate can be estimated, but it will never really be known under this current sampling scheme. I've had a lot of questions around fatalities. So fatalities are a very important number. We're going to get to that in a question in just a moment. Fatalities are one of the metrics that are used that is reviewed by either a coroner, a medical examiner, or a physician in terms to designate what the cause of death is and any underlying conditions that may be contributing to a fatality. This number will always lag our case numbers. And CDC estimates that it can be 28 days or more before mortality actually backfills the graphs that a lot of us are looking at. Hospitalization rates typically will lag again from mortality, and they will they will also lag from our case reports. So cases first, then hospitalizations, then the mortality events. I want to reemphasize too, when we talked about percentages contributing to some of the pie charts versus actually what rates are. So what we are typically producing and what many of you will see are going to be case fatality rates. So that's where you take the number of deaths and you put it over the number of cases reported. That number is going to be artificially elevated because we don't have all the people in the denominator that are asymptomatic and have not been reported as cases. So please understand that as you're trying to dig through the numbers. I also want to say that comparisons between states or countries should be done with, again, the caveat that they're only really comparable if the way in which case assessment is done is the same in these two geographic regions. So, long story short, estimates over time are the best indicator of how we're doing with the response to COVID-19. With the understanding that there are a lot of caveats that will affect both the numerator and the denominator, and it can skew these numbers. So for me as an epidemiologist, I have to be aware of what those caveats are in terms of what the numbers truly mean. And they very often are not what's at face value. Okay. Let me do this. Let me go ahead and go to the questions that we have. What kind of reaction to Mobile schools returning in phases to classes now? So how do we feel about that? This is a very good example of decisions not being made in a vacuum. So although there are very serious consequences to the COVID-19 pandemic, COVID-19 and its effect on keeping people out of work, having to watch children, keeps them, again, from earning a living, and many people need to be in a position to put their children back in class. Additionally, there have been several reports in terms of what is needed from the children. That may be things such as lunch or socialization, and all of that is critical for development. What I would say is that making a decision to put your child back in class learning versus keeping them at home in virtual learning really is a personal decision where you're assessing your risk and your benefits. I think the Mobile County Public School System made a decision that gives the most options to parents and to children while also trying to maintain social distancing, mask, hand washing, disinfecting, etc. AstraZeneca in vaccine production has stopped their clinical trial for their COVID-19 vaccine. How important is that? When vaccines go into development, in their clinical design, they have what's called stopping rules. These stopping rules either are focused on how well that vaccine is supposed to work. So one of the ways that a vaccine program is stopped is if they see very, very low efficacy of the vaccine in challenged populations. The other way, and this is the case of AstraZeneca, is they had a safety event. in the populations vaccinated. So this is what will happen. They will break the blinding and find out if that patient is on their COVID-19 vaccine or if they are on placebo. If they're on placebo, this trial will restart. If they're on the active vaccine, then an assessment is done to understand how rare that event is and whether that event is potentially attributable to the vaccine. So I don't know the specifics around the safety event for AstraZeneca's vaccine, but if you see that it is restarted, the determination was made by their data safety monitoring board that this result in terms of a adverse event did not change the benefit risk of the vaccine. So our next question is about the CDC's excess death report. So this actually comes into play with another question I have around mortality that we'll get off Facebook. If you look at excess mortality on the CDC website, what that's doing is comparing all-cause mortality from what we're seeing now from February 1st, 2020, to the historical averages that were observed from 2005 until February 1st of 2020. And what that does, it adjusts for mortalities that are seasonal. So when you're interpreting the graphs that we have put up on Facebook, it's very important, if you look at the blue graph, you'll notice that there is to the far right, there will be several columns which are the excess deaths, all causes, compared to the average line, which is the threshold. And this is a threshold that's fairly robust. And you can see there are little red dots that are at the upper end of those columns. That is where we have had excess deaths attributable to COVID that are being picked up. And the reason that this is important is that COVID-19 is not simply a disease of the lungs. It's an inflammatory disease, it's a circulatory disease, and it can affect the neural pathways of the body. So it's very important, and this is actually one of the best ways to look at the effect of COVID, is to look at this time frame in comparison to other time frames. The question asks, are we well past the peak? So I caution everybody that where you start to see the blue columns go down at the end of August, those columns haven't been backfilled yet. So we will know in a couple of weeks if we're actually getting a downturn. But some of the graphs that I can look at, and you can too at cdc.gov, still shows an excess for that bar within the month if you look at expected versus actual mortality. Let's see. Our next question is about current schools and whether we're seeing outbreaks here. So the state of Alabama and Mobile County Health Department does get a report that is by school that shows us by grade, by age, the number of individuals that have tested positive and that are currently in quarantine for the 14-day period. The schools have been extremely transparent with that data. Some have rates that are a little elevated and technically do constitute an outbreak. Some do not. What is difficult to determine is whether transmission is occurring inside the schools or if it's occurring outside the schools. So we are looking into that. What is interesting when we look at the school data is we seem to see a spike around Wednesday of each week. That can be due to testing presentation, or it can be due to events that are happening over the weekend. So if you are going out, please remember social distancing and wearing your mask. We also, I apologize for this, we did post 2 additional slides on the website that talk about all-cause mortality think it will be interesting for some of you to look at that and look at some of the bars that are elevated and where you might think that this has nothing to do with COVID-19. Actually, a lot of those bars put you in more of a risk category to become infected with SARS-CoV-2, as well as influence your disease progression in a more deleterious way. All right, let me move on to our Facebook questions. So, will the city be offering any outdoor flu clinics? Yes, we will. We will be offering drive-through clinics. We're doing that to maintain the safety of our personnel as well as the individuals that are in the car. I do not know when COVID-19 vaccines will be available. From my experience as a global epidemiologist over vaccines, it's going to be 2021 at the earliest. So while we are going through mock drills and thinking about and abiding by CDC's recommendation of be ready to distribute, I encourage everyone to also be ready to receive the COVID-19 vaccines when available. They're not all going to be available at one time. So that leads to our next question, which is, would caregivers of individuals that are in high risk of COVID-19 severe outcomes likely to be good candidates for the first rounds of vaccinations? Likely no. What we will do if the vaccine is shown to be efficacious and safe in older populations, we're going to vaccinate them first. And then we will start looking at circles around the high-risk individuals to determine who the next wave or what the next wave should look like. We also would focus on our first responders and make sure that they are vaccinated in the first wave if they should choose to do so. My next question is, can someone please tell me why Clark County and Washington County's COVID numbers drop one day to another? So that's a little bit out of my jurisdiction, but I can say that Clark and Washington are dealing with the same things that we do, where a cumulative number that should never come down actually does drop when cases are reassessed or reclassified. My next question, are postal workers supposed to be wasting masks? No, they should not be wasting masks. I think the question probably should be, are postal workers supposed to be wearing masks? The answer is, if they are within 6 feet of you for 15 minutes cumulative, they absolutely should be wearing masks. But if they're riding around in their truck and not coming into contact people and they're socially distancing, it's not mandated that they wear their mask in their truck. I will remind everyone of Governor Ivey's mask order. It is still in effect through October 2nd. If you are in a public space, you do need to wear your mask. My next question is, I would like very much to see a breakdown of deaths in the older age group, as I am a member. So I can understand the request to have kind of a personalized report. The way that the numbers are broken down are to give those people that have to make decisions around that a biological basis for the age cuts. So the reason we cut certain age groups is because biologically we think that they're going to react similar to the others that are in that age group. So that's what we call homogeneity within an age group. If we start mixing effects, it becomes problematic for us to interpret the data. If we start cutting data too finely, we don't have enough individuals within those categories for those numbers to have any representation to that group. It's virtually a meaningless number with very large confidence intervals. All right, so just a couple of announcements. Mobile County Health Department is partnering with Pet Supplies Plus at 803 Hillcrest Road for a rabies clinic. The clinic will run from 11 to 1, and it is $12 per pet for the vaccination. This is a drive-through clinic, so we are trying to protect those that are giving the vaccines as well as pet owners. And then finally, I'd like to remember those first responders that ran toward the Twin Towers on 9/11 and think about the sacrifice they made while many people were running away. I also want to take this moment to thank all of our first responders that are currently standing on the front lines for us and protecting us in so many ways. So thank you very much. We'll be back on Monday with our expanded report.
How you doing, John?